Okay. Hey guys, thank you for joining our seminar. We're going to be doing endocrine. Um, Obviously, this is just like an overview of the whole subject. You definitely need to go to the lectures, and internet is really good. But the lecture should be your first source because it has a lot of detailed info, and in the credit, I remember there being some detailed questions as well. So, starting with the first part, Tandis, can you move to the next slide, please? Okay, so the hormones of the pancreatic islets, Tandis. Okay, sorry, it didn't show. We have four different types of cells, which are really important to know that are part of the pancreatic islets. I'm sure you guys remember from histo what the islets look like. We need to know the proportions of these different types of cells. You have alpha cells, beta cells, delta cells, and F cells. The alpha cells, there's 20 to 25% of it, and they produce glucagon. Glucagon is known for increasing the glucose levels within the blood. Beta cells, between 60 to 75% of the cells in the islets are beta cells, and they produce insulin, which is one of the most important that you have to know of. It decreases your glucose levels. Delta cells, 5 to 10%, they produce somatostatin, which is the opposite of growth hormone. So, somatotropin will stimulate the production of growth hormone, while somatostatin does the opposite of that. Then F cells are pancreatic polypeptides. They are part of the pancreatic juice. Talking about insulin, which is the most important hormone that you have to know of, it's made up of two polypeptide chains, an A chain and a B chain. The A chain has 21 amino acids and the B chain has 30 amino acids. This is quite important. Now, in the formation of insulin, it starts off with a compound known as proinsulin, which is before the production of insulin, and it has 1/10 of its activity. For proinsulin to become insulin, it needs to lose a specific chain of amino acids, which is known as the C chain, otherwise known as the connecting chain. So once this C chain is removed, then it's called insulin. Now, how insulin is synthesized, it starts in the endoplasmic reticulum of these beta cells. It then moves on to the Golgi apparatus. It's stored in membrane-bound granules, and with an influx of calcium ions and depolarization of the cell, it moves to the cell membrane. Exocytosis takes place, and then through fenestrated capillaries around the pancreas, it's able to move into the bloodstream. Insulin has an effect on a lot of tissues, many tissues, especially in the liver, and it has effect except for tissues like the CNS and erythrocytes, which are properly insulin independent. They degrade in many tissues. 80% of it degrades in the liver and kidney with the enzyme known as insulin protease, and the half-life of insulin is 5 minutes. Next slide, please. Okay, so now the effects of insulin, it's very summarized here, but then this should give you a general idea of what insulin does. The first thing is, in general, insulin tries to reduce glucose levels in the blood. So how it does this is it increases permeability of the membrane of many different types of cells. So it tries to get the cells of certain tissues to take glucose inside the tissues and use them for metabolism and for energy. But insulin is only able to have an effect on the tissues that have this GLUT4 transporter. So there's many different types of GLUT transporters. I'll show it to you on the next slide because you're supposed to know where these GLUT transporters are present. You have from 1 to 5, which are the main GLUT transporters. I think there's 7, but then it's only 1 to 5 that you should know of. GLUT4 is the only transporter that is regulated by insulin. And this type of transporter is present in muscle and adipose tissue. Muscle because it tries to get glucose into the muscle cells so that glucose is used for muscle energy, and also adipose tissue so that glucose can be turned into glycerol and can form fatty acids and can be stored as fat. Then it has an important effect on carbohydrate metabolism. Like I said, in muscle, it's used for energy and it can also be used to store glycogen. In the liver, it's able to inhibit glycogenolysis, because glycogenolysis means glycogen being converted into glucose. It's being broken down into glucose. So we don't want more glucose to be formed. So it's going to inhibit glycogenolysis. It increases the uptake of glucose into the liver by phosphorylating it. So when glucose moves into the liver, insulin is able to stimulate not the movement of glucose into the liver, but a phosphorylating enzyme which phosphorylates glucose. Once glucose is phosphorylated, it can't move back out of the liver. So that means it just stays there. And it's able to activate enzymes for glycogen synthesis. So glucose moves into the liver, and then they try to reduce the amount of glucose by producing glycogen with it. So the enzymes that are stimulated are phosphofructokinase and glycogen synthase. And it's able to inhibit gluconeogenesis, again, reduce glucose, and it's able to convert glucose to fatty acids. Then talking about fat metabolism, first of all, it's able to inhibit hormone-sensitive lipase. Hormone-sensitive lipase, what it does is, you'll understand it a bit more when you come into biochemistry, but then hormone-sensitive lipase is able to break down some kind of fats or fatty acids in the blood. And when this breaks down, then that means that fats will be used as a source of energy. I will let these people in, Alaa. It will allow for fats to be used for a source of energy instead of glucose, which insulin doesn't want, because obviously it wants glucose to be used as its primary source of energy. And it promotes glucose transport into adipose tissue. And the problem is when there's a lack of insulin, more fat is broken down within the blood, because insulin's function is inhibiting hormone sensitive lipase. When this inhibition is not taking place, hormone sensitive lipase is very active. It's able to break down fats. And when fats are broken down, it can form compounds like beta hydroxybutyric acid, acetoacetic acid. All of these are acids that cause ketoacidosis and causes the body to become more acidic. And there's a lot of that you need to know about. It's going to be in the lecture. It's more explained. I can explain it to you now. If you want me, I can explain it, but then it's a lot of info. So I would recommend you watching a video about it. But if you have a question, I can explain that as well. Protein metabolism is also one of insulin's effects, where it has decreased catabolism. That means insulin tries to build up protein, and it has kind of an anabolic effect, but then it's never said that it's a direct anabolic effect. It's a decreased catabolic effect, and it increases the permeability of cell membrane for amino acids. Now, we have two non-metabolic effects of insulin. There's no way to make sense of these 2 points. You just have to memorize. There is a mild antidiuretic effect. Antidiuretic means that water is reabsorbed into the body. It's not allowed to pass into the urine. And it has hypoglycemic doses of insulin can also induce lung edema. That means a large amount of insulin where it will cause hypoglycemia can induce lung edema. The next slide, please, Tandis. So like I was saying, there are important GLUT transporters. You have to memorize this chart because it's quite important. It comes in the test quite frequently, where GLUT1 is present, GLUT2 is present, GLUT3 is present, GLUT4, GLUT5. I can read it out to you, but then the most important is knowing that GLUT2 is on GLUT4, which is insulin dependent, is in the skeletal muscle and in the adipose tissue. But you need to know where each of these GLUT transporters are present, and if they're insulin dependent, how their Km is, how their affinity is. You need to just memorize this whole table. Next slide, please. So insulin, like I said, insulin, there's many types of receptors, many types of transporters along many tissues. Now, the insulin receptor, which is what allows insulin to have its effect on all these different tissues, is made up of 2 alpha and 2 beta subunits. And these 2 receptor compounds are joined by a disulfide bond. Now, the control of insulin secretion. What controls insulin is first the simple feedback of glucose versus insulin. When glucose is very high, it stimulates insulin to be secreted. When glucose is very low, it inhibits the secretion of insulin because it's kind of done its job. Autoregulation, that means when the concentration of insulin is really high in the blood, it will stop the pancreas from producing any more insulin. So that's autoregulation, just from the concentration of insulin already present in the blood. Now, there's hormones of GIT, for example, like secretin, cholecystokinin. All of these are hormones of the GIT, and they stimulate the production of insulin. Why this is because, like, after eating, in your small intestine, once it starts to absorb all these foods, you have hormones of GIT that activate, and they realize that there's absorption taking place. And if there's no action taken by insulin, there'll be a very high amount of glucose within the blood. So to avoid this, the hormones of GIT also stimulate insulin secretion. Then you have epinephrine and norepinephrine, which are your catecholamines. They have an inhibitory effect on insulin. You have incretins. Incretins are also known as enzymes that they're kind of like hormones of GIT. So after eating, it sees the absorption from the small intestine and goes and stimulates insulin. It has many more other functions, but that's all you have to know about incretins for insulin. Then you have growth hormone and glucocorticoids like cortisol, which stimulate the production of insulin. You have the right vagus nerve. There's no physiological explanation for this, but just know that it also has a stimulatory effect. I remember this being asked in the test. And then you have some derivatives of sulfonylurea. All you need to know about sulfonylurea is it's an anti-diabetic drug. So, in diabetes, it's where someone has very high glucose levels. So, to avoid this as anti-diabetic, that's why it stimulates insulin. Next slide, please. Now, we already know what the effect of is with insulin. Now, in diabetes mellitus, it is the case where either the body has no insulin production, which is seen in diabetes mellitus type 1, or reduced sensitivity to insulin, which is diabetes mellitus type 2. This differentiation is there in your lectures, so please do go through it. But just overall, what happens in diabetes mellitus? First, the carbohydrates. You're going to have hyperglycemia because there's no effective insulin. Glucose is very high in the blood. There's glycosuria because when glucose is so high in the blood and it goes over 10 millimoles per liter, which is your renal threshold for glucose, then the kidney is not able to sufficiently reabsorb glucose because it's way too high. So glucose leaves the body through urine. And when glucose is a osmotically active molecule, and what that means is it's able to control the osmotic gradient. And because when there's glucose in the urine, that means there's some kind of solute in the urine. So what happens is water moves in as well to balance the osmotic gradient. So you're gonna have a lot a lot of water as well moving in your urine, and this causes polyuria. When a lot of water is lost from your body, it causes dehydration and it makes you thirsty, polydipsia. So you'll see this as a being thirsty as a symptom of diabetes mellitus in old people. Now for protein, sorry, for protein, diabetes, it increases the protein catabolism. Like we said, insulin, it has an anabolic. Sorry, previous slide on this. It has an anabolic effect. So when insulin is not there, it's going to have a protein catabolic effect. It increases gluconeogenesis from proteins as well, and there's a reduced amino acid entry into cells. So everything that is functioning of insulin is reduced here. With lipids, it increases the breakdown of lipids and it decreases lipid synthesis. And because of this, like I said, there's a lot of end products that are acidic that comes out of the breakdown of fats, like beta hydroxybutyric acid, and this causes ketoacidosis. And like I said before as well, dehydration. And when you have this dehydration, there's not enough water in the extracellular fluid. So the water from cells start to move out of the cells to again balance the osmotic gradient. And this happens with neurons, where neurons start becoming smaller and shrinking just because water moves out of the neuron cells into the ECF. And this can cause coma and a lot of brain damage and other symptoms like this. Next slide, please, Tandis. So that was like a small summary about insulin, the pancreatic gland hormones. Go through the lecture because it has more, there's more content about diabetes and the insulin structure, which is quite important as well. Now, going over the thyroid gland, you need to know the size of it is about 2 to 4 centimeters. It's about here. The weight is about 20 grams. Blood flow is 80 to 120 milliliters per minute. This wasn't asked in the test, but they always say it's quite important. It's surrounded by a basement layer, like if you well, you guys should remember from histology, it's a single layer of circular nuclei with circular nuclei. And inside the lumen of these big follicles, it contains thyroid hormones and it's stored in a colloid form. It's known as thyroglobulin. So that is where all of the thyroid hormone production takes place. Next slide, please, Tandis. About the synthesis of thyroid hormones, it's quite simple. So, iodide is needed for this whole process. So, iodide is captured from the blood and it's taken into the colloid. They have some transporters, and this whole part is called iodide trapping. And it's a very efficient process because the concentration of iodide within the gland is about 30 to 40 times than what's in the plasma. And this is also a way to evaluate the activity of the thyroid gland. You're able to give it iodine that's fluorescent, and then you can use like some kind of fluorescent screening to visualize the thyroid gland to see if it's hypertrophic, hypotrophic, and see its whole activity. Now, this iodide moves into the thyroid gland and it undergoes oxidation by the enzyme peroxidase. So from iodide, it's converted to iodine. And this iodine, it is used for the iodination of tyrosines within the colloid, the thyroglobulin molecule. One iodine with tyrosine is known as monoiodotyrosine. Two iodines with tyrosine is known as diiodotyrosine. And then the coupling of DIT and MIT takes place to form T3, T4. T3 is thyroxine. No, T4 is thyroxine and T3 is tetraiodothyronine. Now, T3 and T4, they are present within the colloid still, and they're attached to thyroglobulin. So for it to be removed from thyroglobulin, penocytosis takes place inside these kind of small vesicles, and a lysosome fuses with this and it separates the thyroglobulin from the thyroid hormones with lysosomal proteases. And then the thyroid hormones are then released into the blood. When it's in the blood, it always travels with a plasma protein, so it's bound to them. And you have three different types that you're supposed to know of: thyroxine binding globulin, thyroxine binding prealbumin, and albumin. You're supposed to know these percentages of the different bound plasma proteins because that was asked. There was a question that asked us that. Okay, next slide, please, Candice. Now, the degradation of thyroid hormones, it undergoes first deiodination. So that means the iodine molecule is removed from the hormone. And you're supposed to know what the enzymes are for the deiodination, which is 5' deiodinase and 5-deiodinase, which are able to deiodinate two different types of molecules to fully degrade the thyroid hormone. Then once it's deiodinated, for it to be removed from stool, it needs to be conjugated because it needs to pass through with the bile. So it gets conjugated. It can form compounds known as glucuronides and sulfates, and then it's able to be a part of the bile. And the bile passes from the gallbladder and the liver into the intestine. And a part of this moves through the stool, while a part of it is reabsorbed again while it's in the intestine. If it gets reabsorbed again, then it undergoes oxidative deamination, where it is converted to tetra and triiodothyroacetic acid. Then the effects of thyroid hormone. There's a lot of effects. I've summarized it into a very short paragraph, but it's better for you guys to also know like the different enzymes that's listed in the lecture. This is just for your understanding. So it has a calorigenic effect, which means the thyroid hormones, it increases the metabolic effect on in the body. It has a carbohydrate metabolic effect. That means it increases the uptake of glucose by the cell. It undergoes glycolysis and stimulates gluconeogenesis. And it increases the rate of absorption of glucose. It has an effect on lipid metabolism, where lipids are moved, it's moved from the adipose tissue out, and there's decrease of cholesterol level. Somehow it also decreases cholesterol level, which is beneficial for the body. And for proteins, it breaks down proteins, so it causes muscle weakness. For growth and development, thyroid hormones are needed for normal growth and skeletal maturation. It has a potentiative effect of growth hormone. So growth hormone, it obviously allows growth, development, so it is able to help growth hormone. It has an effect on CVS, where the cardiovascular system, where because of this increased metabolism with the calorigenic effect, there's a lot of metabolic end products. Now, these metabolic end products, it causes normal vessels to undergo vasodilation. And this increases blood flow and overall increases cardiac output. So it's seen to have a permissive effect on catecholamines. And you have a direct effect on excitability and on beta adrenergic receptors, where it increases both inotropic and chronotropy in the heart. Then you have the effect on nervous system, where it's the exact effect is not given to us, but then if there's hypothyroidism, it causes cretinism, which is like brain retardation. Then the relation to catecholamines, it increases the efficiency of catecholamines. Like I said, the permissive effect. Next slide, please, Tandis. Okay, so about hyperthyroidism, it's very important. There's a lot of slides in your lectures, but you have to know the symptoms of each individually. First, starting with hyperthyroidism, it causes weight loss because there's a lot of metabolism. It increases sweating. It causes heat intolerance. It causes muscle weakness. It can cause diarrhea and puffy or bulging eyes, racing heart. When you look at all the effects of the thyroid hormones, all of these symptoms make sense. One of the diseases that's very important is Graves' Bassett disease. So what happens in Graves' Bassett disease is there's increased production of a certain antibody that looks like thyroid stimulating hormones. So it stimulates the thyroid to produce more thyroids because more thyroid hormones because there's some antibodies that look like the thyroid stimulating hormone. So that's the whole basis of Graves' Bassett disease. Then for hyperthyroidism, it's the opposite of hyperthyroidism, where you have cold intolerance. There's weight gain, even though you have decreased appetite. You have constipation, depression, irritability, slow heart rate, a puffy face known as myxedema, which is where like these mucopolysaccharides are they what is it? They conjugate with the proteins and it forms like this like a non-pitting edema. So there's a lot more symptoms and a lot more description on these things in your lectures. So definitely go through those. Yeah, but that's all for thyroid hormones.
Okay, I'm gonna explain hypophysis now. Uh, Okay, so hypophysis, it's an endocrine gland in the brain, which it has an anterior part and a posterior part. The anterior part, it secretes hormones, which some of them have regulatory functions on peripheral endocrine glands, and they're known as tropins. There are five tropins that are mentioned here. I'll explain it in the next slide because I wrote the explanations there. But there are two other hormones that have direct effects on some tissues, which is somatotropin or the growth hormone and prolactin. I'll explain the effects in the following slides. Okay, so I'll start first with ACTH. It affects the adrenal cortex and it stimulates cortisol and aldosterone secretion. Then we have the thyroid stimulating hormone, which stimulates all the steps that the ones that Katie explained in the cycle. They will stimulate all the steps and will increase production of T3 and T4. These hormones, they work like their regulation is based on the feedback loop. So basically, if T3 and T4, for example, if they increase in the blood, TSH will decrease. So that's why they are regulating. Like that's how the mechanism is. Then we have LH and FSH. These two, they affect the genital system, and so the effects for male and female is going to be different. LH for female, it's responsible for ovulation and luteinization. That's why it's called luteinizing hormone, and it regulates secretion of female sex hormones. In men, it stimulates the interstitial Leydig cells to secrete testosterone. And after that, FSH, it stimulates the growth and development of follicles, the Graafian follicles, and it stimulates secretion of estrogen. And in male, it is necessary for spermatogenesis. Prolactin, it affects the production of milk and breast development. It's not that important, honestly. Like, it doesn't have that many effects. That's why I only wrote like one sentence for it here. But growth hormone, it's really important, so I'll explain it like more in the next slide. Okay, so the effects of growth hormone, it affects like generally, it has a lot of effects, but the main responsibility of growth hormone is to regulate the overall body growth. But it's also important in regulation of metabolism. Here, as you can see, I explained like how it affects each step in metabolism. For proteins, it will increase the proteosynthesis and it will decrease protein catabolism. Um, in lipids, it will cause fat utilization and as a source of energy, and it will stimulate beta oxidation. For carbohydrate metabolism, it will increase glycogen synthesis and it will decrease glucose metabolism. So basically, it increases the insulin secretion. And then for connective tissue, it has an indirect effect on bone growth and it will affect it through the insulin-like growth factors. Now, the posterior part of the pituitary gland, it's also known as neurohypophysis. It produces two types of hormones, ADH and oxytocin. ADH, its main function is to regulate the not kidneys, but like the concentration ability and the dilution ability of the kidneys. So what it does is it will increase um, the water channels, which are known as aquaporins, in the distal tubules and the collecting tubules. And because they are impermeable to water, so without ADH, we can't have reabsorption of water in the distal tubule and the collecting ducts. So we need ADH in this case, and it will cause it to be like permeable to water, and we will have reabsorption of water in this case. Another function of ADH, which is less important, and I haven't mentioned it here, it will cause vasoconstriction in the arterioles and will increase arterial pressure. Another hormone that we have in the neurohypophysis is oxytocin. Oxytocin, it affects the uterus during birth and it has a really important role in childbirth. It will cause contractions of the uterus and it will also affect the myoepithelial cells that surround the alveoli in the mammary gland. So it will help ejection of milk. And in male, it's responsible for the general sexual behavior in male. Okay, I'll explain parathyroid here. Parathyroid gland is a small gland. It's located behind the thyroid, and its main function is to control the calcium level in the blood. And the hormone that it produces is parathyroid hormone or parathormone, and it is responsible to increase blood calcium level by releasing calcium from the bones, increasing calcium absorption from intestine, and reducing calcium excretion by kidneys. Okay, so I've written the detailed like explanation over here. Well, for sure there are more details in your lecture, but like compared to the last slide. So how does it affect the bones? We say that parathormone causes the absorption of calcium and phosphate, which is opposite to calcitonin. Calcitonin is a hormone that is produced by the thyroid gland, and they're antagonists with parathormone. And the immediate effect, it has two effects on bones. It has an immediate effect and a slow effect. The immediate effect, it will take a few minutes and it will cause stimulation of osteocytes, but the slow effect, which will take days to weeks, it will stimulate osteoclasts. Another target organ for parathormone is the kidneys, and it will target the distal tubules and the collecting ducts, and it will increase the calcium level in the blood by increasing the tubular reabsorption of calcium, increasing loss of phosphate in urine, and increasing reabsorption of magnesium and hydrogen while excretion of sodium and potassium and amino acids are happening. The last one, which I'll talk about, is the intestine. The parathormone enhances both like calcium and phosphate absorption from the intestine, and it will stimulate calcitriol formation in the kidney. There are two diseases that are associated with parathyroid. One is hypoparathyroidism and one hyperparathyroidism. In hypoparathyroidism, we will have increased calcium concentration in the extracellular fluid, which it is hypocalcemia, meaning that we will have decreased calcium level in the blood, and it will increase neuromuscular excitability, which, if it affects the respiratory muscles, it can lead to death. The other disease is hyperparathyroidism, which hypercalcemia, it can cause depression of CNS and the peripheral activity. It causes muscular weakness, constipation, abdominal pain, and formation of kidney stones. If the hyperparathyroidism affects the bones, it will cause demineralization of the bones, which is called osteoporosis, and formation of large cystic areas. And because the bones become weaker, they will be more fragile, and like there's an increased tendency to fractures. And it can also lead to chemical death. If the calcium concentration rises up to 4 millimoles per liter, you will have depressed relaxation of the heart. So we have stopped systole, and it will lead to death. And I think I'm done. Yeah.
Okay, we can start. This is just the title. You can like move to, yeah. Okay, so the menstrual cycle is divided into 4 phases: the follicular phase, ovulation, the luteal phase, and menstruation. These are regulated by hormonal fluctuations involving FSH, LH, estrogen, and progesterone. And each phase is basically we're just preparing the female body for possible pregnancy. Now, in the follicular phase, it starts on the first day of the cycle of menstruation, of the menstrual cycle. FSH stimulates follicle growth, and the dominant follicle, because there are multiple follicles, but only one actually grows and releases an ovum. So only the dominant follicle begins producing estrogen. Estrogen then stimulates endometrial proliferation in the uterus and eventually inhibits FSH through negative feedback, preparing the body for ovulation. As for ovulation, it occurs around day 14 of our 28-day cycle, the menstrual cycle. Is triggered by a surge in LH caused by sustained high estrogen. The dominant follicle releases the ovum, and this marks the end of the follicular phase and the beginning of the luteal phase. I think this is the next slide. Okay. Now, for the luteal phase, there are 2 parts. The parts where we have the corpus luteum and the parts where we have hormonal feedback. So in the first part of the luteal phase, that part follows ovulation, and it's named after the corpus luteum. LH causes which is luteinizing hormone, causes the follicle to transform into the corpus luteum, which secretes progesterone and some estrogen. So guys, keep in mind during the menstrual cycle, like we always have those 4 hormones: LH, FSH, estrogen, and progesterone. They're just at different ratios. So right now, the progesterone and LH are more than FSH and estrogen. This progesterone maintains the endometrial lining for potential implantation. So in case pregnancy happens, placenta can grow and zygote can be implanted within the endometrium that's thickened. And as for the second part of the luteal phase, the corpus luteum also secretes inhibin, which suppresses FSH. So if fertilization doesn't occur, the corpus luteum starts degenerating about 4 days before menstruation, causing a drop in progesterone, estrogen, and inhibin. Now, this hormone drop lifts the suppression of FSH and LH, allowing the next cycle to begin. Okay, you can move. Okay, for menstruation, it's caused by a fall in progesterone, estrogen. Without these hormones, the endometrial lining can no longer be maintained, and it sheds, which causes the menstrual bleeding. This is the start of a new cycle, and rising FSH levels begin the follicular phase again. So the cycle will start again. Okay. You can, yeah. All right, now for estrogen and progesterone. Estrogen is produced by developing follicles and the corpus luteum. It helps in growing the endometrial lining. and provides negative feedback on FSH and triggers the LH surge for ovulation. It also supports uterine preparation for implantation. As for progesterone, it's mainly secreted by the corpus luteum. It stabilizes the endometrial lining and inhibits uterine contractions. If pregnancy occurs, it continues to be secreted. If not, its decline triggers menstruation. All right. As for pregnancy and giving birth, if fertilization happens, HCG maintains the corpus luteum. This ensures continued progesterone estrogen production to maintain the endometrium. Later, a drop in progesterone will help initiate labor. And also there will be increased oxytocin. And oxytocin basically helps two types of contractions, the contractions of the uterus and also the contractions of the breast and the nipples for milk production during lactation. All right, you can move to the next slide. Lactation is inhibited during pregnancy by high estrogen and progesterone. After childbirth, their levels fall, which allows prolactin to stimulate milk production. Oxytocin helps with milk ejection in response to infant suckling, which we mentioned already. All right, so that's it for the menstrual cycle and pregnancy and giving birth and lactation. Now we can move on to the adrenal gland, I believe, in the next slide. All right. Okay, you can move to the next slide. All right, so the adrenal glands, they sit above the kidneys, which is why they're also called the suprarenal glands. And they have two parts, the cortex and the medulla. The cortex produces steroid hormones, which we will delve deeper into during the next slides, while the medulla produces catecholamines, which are involved in the fight or flight response in the sympathetic nervous system. Okay. Now, the adrenal cortex zones consist of three layers, glomerulosa, fasciculata, and reticularis. How I remember it is just GFR, which is also linked to the kidney since they're above the kidney. Each layer produces a different class of steroid hormone, mineralocorticoids, glucocorticoids, and androgens. So we can move on. So for the first zone, zona glomerulosa, it's the outermost layer and it produces aldosterone. Aldosterone regulates sodium and potassium balance and so controls blood pressure. It's regulated by the renin-angiotensin system and the potassium levels in our body. Okay. As for zona fasciculata, it's the middle layer and it secretes cortisol, which is the primary glucocorticoid. Cortisol increases glucose levels, breaks down proteins, and suppresses inflammation. It's controlled by the CRH-ACTH axis, which involves the hypothalamus and the pituitary gland, and it follows a negative feedback mechanism. So basically, our body senses when it increases and decreases, so our body knows whether it should produce more or less. Okay. All right. As for zona reticularis, it's the innermost layer and it produces adrenal androgens like DHEA. These hormones, they're precursors to testosterone and estrogen. They play a more significant role in female physiology, especially for secondary sexual characteristics after puberty. Okay. As for the adrenal medulla, it's composed of chromaffin cells and it secretes adrenaline and noradrenaline. These catecholamines prepare the body for stress by increasing heart rate, blood pressure, and energy mobilization, so breaking down energy stores. Secretion of adrenaline and noradrenaline is triggered by the sympathetic stimulation. All right. Okay, as for the regulation of these hormones, each group is regulated differently. So aldosterone is regulated by RAS and potassium. Cortisol and androgens are controlled by ACTH, and catecholamines are released by neural input from the sympathetic system. Okay. As for the slide, it just sums up the effects of all the adrenal hormones. So aldosterone controls electrolytes like potassium, sodium, and even hydrogen ions and blood pressure. Cortisol manages stress and metabolism. DHEA is a sex hormone precursor, and catecholamines trigger the fight or flight response. Okay. As for the clinical relevance of all the hormones we just mentioned, we can see that there are some syndromes linked to them. So any dysfunction, so any increase or decrease. So if there's too much cortisol, we can develop Cushing's syndrome, which is its main feature is moon phase, and centripetal obesity. As for Addison's disease, it's a deficiency in adrenal hormones. Const syndrome involves excess aldosterone, and pheochromocytoma is a tumor which produces catecholamines or catecholamines. I think that's it for me.